start. So thank you for starting the recording, and I will begin with the land acknowledgement statement. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. Thank you. So this is the Incarceration Prevention and Reduction Task Force Joint Behavioral Health and Legal and Justice Systems Committee. We meet together quarterly. And so welcome, everybody. My name is Raylene King. I am the chair of the Legal and Justice Committee, and Mike Parker and Dan Hamill are the co-chairs for the Behavioral Health Committee. So I'm going to actually turn it over to Dan and Mike to introduce the first presentation regarding the 988 Suicide and Crisis Lifeline.
Thanks, Raylene. You caught me with a mouthful of sandwich. Sorry about that.
Sorry, I was trying to go slow.
No, you're good. You're totally good. I think Mike's going to join us a little bit late
Okay.
here this morning, but he should be here. He should arrive momentarily. Jill Nixon, can you put up the agenda and go down to the first item, the 988? Okay, so this is the presentation from Brian Estes, who is a co-chair for the local chapter of NAMI, and Brian's going to take us through the 988 Suicide and Crisis Lifeline, and we've got a couple of other folks here from Volunteers of America, and I'm going to let Brian do the intros on that. So Brian, go ahead and take it away.
Thanks, Dan. I love Mac. I'm not. Hold on a second here. Okay, there we go. Can you all see that?
Yes, we can.
Okay, so 988, I'm just going to give a brief overview of the 988 system and why we need it, and then I'll turn it over to Reed and others at the Volunteers of America, who many of you know manage the 988 system throughout most of Washington State. So more broadly, the new 988 system is reimagining crisis response. A crisis system that provides people help with someone to talk to, someone to respond, and a safe place to go. So the old suicide prevention hotline has been renamed the 988 Suicide and Crisis Lifeline. So it's much broader than it used to be, and it really is dealing with anyone experiencing emotional distress to call or to call on behalf of someone you care about. So why do we need this? So many Americans are afraid to call 911 because they think themselves or a loved one would be hurt when responding to a mental health crisis. This is particularly true for Black, Hispanic, and LGBTQ Americans, and this data comes from a survey that NAMI did in June of 2003. So how familiar are people with 988? It rolled out in July of 2022. 82% of Americans are not familiar with 988. So there has been some improvement, as you can see in this graph, over the years, but still, most Americans are not very familiar or have even heard of 988. The people that are most likely to have heard of it are young people 18 to 29 and the LGBTQ community. So, and also many people don't know much about what to expect when they call 988. I'm going through these slides very quickly. I just wanted to give you a broad brush of some facts about the 988 system. And a mental health response is seen by almost all Americans as appropriate, as opposed to a law enforcement response when somebody is in a mental health or suicide crisis. So what will it take to build a crisis response system? It takes federal, state, and local action together to implement best practices so that everyone in crisis gets the help they need when they need it. And are there best practices for a crisis response system? Yes, there are. SAMHSA, who many of you are familiar with, developed this behavioral health crisis care toolkit a couple of years ago, and it's very good and shows a lot of gaps when you compare this to what we're doing here locally, but we are doing a number of great things here locally in Whatcom County, much more than many other counties in Washington State. I wanted to point out one graph from this best practices. And if you can see in the lower right corner, this compares costs associated with crisis response under our sort of no crisis care system, if you want to characterize it like that, to a fully developed crisis response, very robust system. And the cost differential is 52% lower when we have a robust crisis response system. So there are also efforts in our own state. The CRIS committee was formed in 2021 and is working on improvements to the 988 system with all three facets. And with that, I will turn it over to Reed Johnson, who is the phone's program manager, and he can introduce the rest of his people that he works with. Reed?
Thanks, Brian. I'm going to go ahead and share my screen. All right. Can everybody see that? Perfect. All right. So yeah, my name is Reed Johnson. I'm the 988 Phones Program Manager at VOA. With me, I have Courtney Caldwell. She's the 988 Director. And then Caitlin Magarani, who is the 988 Chat and Text Program Coordinator for Washington State. So we're going to each kind of give you a brief rundown of some of the functions of 988 within Washington State. And then at the end, we'll have a little bit of time for a question and answer if you guys have specific questions about things. So go ahead and get started. So kind of some of the current programming that we're going to talk about here today. So the 988 Phones Crisis Center, kind of like I alluded to, we take calls from all over Washington State, 32 of the 39 counties specifically. Some of the stuff that we do, so 988 follow-up services, you'll hear me refer to it as FUS. That's a kind of a section within 988 Phones where we have dedicated staff that follow up and reach out to people as opposed to having people reach out to 988. Another line that we operate is the Native and Strong Lifeline. That's a 988 and Lifeline dedicated solely to Native Americans. And then there's also the 988/911 Crisis Call Diversion Program. It's currently operating in Pierce County, and Courtney will tell you a little bit more about that. And then there's the 988 Chat and Text Center for Washington State, and we take 988 chat and text from all over the state. So kind of starting out, we take 988 calls from 32 of the 39 counties. In Washington State, there's basically 3 call centers that take 988 calls. There's us, we're in Everett. And then there's Crisis Connections in King County and Seattle. And then there's Frontier Behavioral Health over in Spokane. Just kind of like a really brief rundown and overview of what we've done, especially over the last year. So 44,000 calls answered in 2023. For Whatcom County specifically, just in the month of February, we had 243 calls. 988 follow-up services, which I'll go into here shortly, serves every county in Washington, so not just 32 of 39. If you're living in Washington at the time, then you're eligible for the 988 follow-up services. And then the follow-up services is pretty new. It's new within the last 10 months or so. We've really kind of ramped it up, both with staffing and just the amount of people that we're able to connect with. And we've completed like 2,000 plus follow-up calls just this year. And we have about 40 people that are kind of on a caseload of sorts, spread out amongst the 10 staff that we have. So some of just very generally like what happens when you dial into 988. So when you dial 988 from a phone that has a Washington area code, it's going to keep you in your region essentially. So if you have an area code that's from King County, you're going to go to the crisis connections, same with Spokane over there. But any of the other counties, you're going to come to us. It's going to give you 5 options essentially. Option 1 is pressing 1, and that will take you to the Veterans Crisis Line. Pressing 2 will take you to the Spanish Lifeline. 3 to LGBTQ. 4 takes you to Native and Strong, which, like I said, is operated by us. And then 5, the last option is you can either press 0 at any time and you'll be connected directly with somebody, or you can just stay on the line and then you'll be eventually connected with somebody. The whole process typically takes 30 seconds or less to get through that phone tree. It's built to be as quick as possible because when people are calling in crisis, it's not the best to have them waiting for long periods of time trying to connect them to somebody. With FUS, kind of as I previewed earlier, so FUS is relatively new. We started it last year in April or May of last year. Currently, we have 10 full-time clinicians that operate on a 24/7 every day of the year. Callers are enrolled into FUS via referrals from either the chat and text program or from the 988 phones. And that referral, it looks like it's basically a process where the counselor talks to the person and offers it to them as a kind of an intervention option. And so FUS is a service that works with people over a short period of time. Usually it's between 3 and 6 weeks. It has a really heavy focus on safety planning around the current crisis and, suicidal thoughts. And then once that person is kind of stable, after a week or so, sometimes it's longer. But then the FUS clinician can really start focusing on like connecting to resources, connecting to natural supports, trying to kind of basically give the people a scaffolding of sorts to be able to then move on their own. And then they graduate after 4 to 6 weeks, and they are going to try some of those coping skills, try some of those things. And if it doesn't work, they can always call back in and be re-enrolled into the FUS process. So as far as who's eligible in Washington, so you have to be 13 years older. You have to be willing to engage in services and receive a call. You have to reside in Washington State, and then you can't be in a current suicidal or homicidal crisis. So it can't be something that's an imminent, or somebody that has an imminent danger to themselves or somebody else. So another aspect of what we do and a line that we operate is the Native and Strong Lifeline. So it's dedicated specifically for Indian or Alaskan Native Americans. And it's also staffed by people that have a tribal affiliation. The calls, when they're answered, the person answers with their tribal affiliation. It's been very successful. Again, it's a relatively new thing, especially within Washington State and across the country. And so it's been very cool to kind of see it grow and see it continue to be utilized. So I'll hand it over to Courtney, and she will talk about the 988/911 call diversion program.
All right, thank you, Reed. So really excited to talk about this program, the first of its kind launched in Washington State last June. So the vision for this program is to divert those mental health calls that reach 911 and contain a mental health component so that they can receive a mental health response, whether that's an intervention via 988 or some type of in-person response that is mental health in nature. And so the goal behind this is to divert resources from, or divert utilization of resources from the 911 and law enforcement system. So those resources can be allocated to other emergencies, as well as provide the community with a mental health response for mental health calls. So in 2023, we did have one 988 counselor co-located on site at South Sound 911. We're excited to be expanding to 24/7 coverage in 2024. We're actively recruiting and staffing that up. And then last year, we did see an average of 82% complete diversion rate of those 911 calls that our 988 counselor interacted with, which is pretty consistent with what we're seeing in other models across the country, like the diversion program in Austin, Houston, and Tucson. Next slide, please. So in this program, these are kind of just a snapshot of the transfer criteria. There are two types of ways the 988 counselors co-located on site will interact with the 911 calls. So one of those is a flat transfer where 988 is treated as the primary response. So they're actually dispatched through the same system that law enforcement and other responses will interact with 911 calls. And so those are when the caller maybe has thoughts of suicide, but there's no immediate threat to self or others, or they're with someone who's in that situation. Also, familiar callers at baseline will be given the flat transfer. And then the other type is a de-escalation conference call. So that's where the 988 crisis counselor will assist in de-escalating whatever situation is going on while dispatch has already been alerted and units are en route. Next slide, please. So this is kind of an overview of our outcomes for 2023. We had 565 calls that reached 911 that involved our 988 counselor interacting with those calls. Of those calls, over 460 were flat transfers and almost 100 were assistance-based conference calls. So of these outcomes, the ones with stars next to them indicate that the crisis was resolved or de-escalated to a point where we can assume the person in the community calling was safe. So there was an 82% total diversion rate. So that means that 82% of the 565 calls were diverted completely from the 911 and law enforcement systems. Next slide, please. And so we've seen some really positive impacts from this program, both on the caller side, feeling like they have options out there. They know they can contact 988 in the future, and then as well as on the PSAP side. So our 911 call takers and dispatchers at South Sound 911 have found this program to be a great relief, both because it frees up a little bit of their time and they feel like their community members, especially the familiar callers, they might become familiar with and develop a lot of feelings of care and compassion for. They know that they're getting good help and follow-up. A lot of those calls we interact with in this diversion program are referred to our follow-up service. So it's more than just a one and done. There's follow-up to make sure that the people get connected to the resources they need.
And here you can take a closer look at the path that unfolds through our 988 Washington chat and text services. This slide details each step of the process from the moment of initial contact to the ongoing support we provide. It starts with the initial contact. An individual in crisis reaches out via chat or text, initiating a conversation with a trained crisis counselor. Our services ensure a rapid response with counselors engaging with the individual within seconds to provide immediate support. Then counselors employ active listening techniques to understand the individual's feelings, circumstances, and the nature of their crisis, focusing on any suicidal thoughts or intentions. Then through a compassionate and structured dialogue, counselors assess the risk level of suicide or self-harm to determine the most appropriate intervention. Next, we utilize evidence-based practices, and counselors work to de-escalate the situation, offering emotional support, coping strategies, and hope. And then depending on the individual's needs, counselors may provide referrals to local mental health services, suicide prevention resources, or emergency services if immediate intervention is required. And if appropriate, the service may offer follow-up call support to ensure the individual remains safe and connected to ongoing support. The FUS program takes the initiative in this process, showcasing how our different programs work together cohesively. And throughout the process, the individual's privacy is respected, with all conversations held in strict confidence unless there is an immediate threat to life. And finally, the 988 Washington chat and text service is available 24/7, ensuring individuals can access support whenever they may need it. Next slide. And now you can take a look at some of our client statements where the real heart of our impact shines through the voices of those we've helped. These testimonials here range from a 14-year-old in Tacoma to a senior citizen in Seattle, each sharing their story of crisis and comfort. It's a vivid illustration of how our 988 services provide that critical lifeline across all generations. These words of thanks and hope affirm the wide-reaching and essential support that we offer no matter the age. And reflecting on these testimonials, you can see how they reinforce the value of the work we do every day. Thank you.
Cool, thank you guys. So that's kind of our little brief rundown of 988 services and some of the things that we offer. So we like to leave a little bit of time at the end just for like a question and answer. You know, if anybody has questions or things just in general or about things specifically. Courtney does have to leave at about 12:10. But certainly, yeah, if anybody has questions or any thoughts, please let us know.
Okay, thank you for the presentation this morning here. Thanks to Courtney, Reed, and Caitlin. And I see Courtney from the from Public Defender's hand is up.
Thank you for the presentation. It just makes me so excited about 988. And I'm just curious, like in a perfect world scenario, how much staff would you have? Because I know 10 clinicians is probably far from enough. And we really need to see this everywhere. I mean, there's so much changes when the right people are connected to people in crisis. And I mean, as we all know, that we expect way too much of law enforcement. They should not be responding to a lot of these calls. And 988 is a perfect example of like the things that are possible when we reimagine how we respond to mental health crisis. And I just really love the presentation. And how many staff do you guys need?
Absolutely, yeah. So I'll clarify that a little bit. So the 10 staff is just within our FUS services. In total for 988 phones, I think we currently have 45 total staff. And to just kind of give you an example of how that ramped up with the 3-digit number. So back prior to July 2022, we had anywhere from like 1 to 4 staff who were just dedicated to taking lifeline calls at that time. Then the number changed down to the 3-digit number, and we now have 45. So it went from 1 to 4 to 45 people. So that's kind of that shows the need, I guess, and the increase of calls that we've experienced just with that change.
It's so needed. Thank you. Yeah, and with COVID, you're going to get more calls. I mean,
Yeah.
people, everybody's life has hit the fan.
Mm-hmm. Thank you.
Peter Frazier, I see your hand up.
Thanks for the presentation. Really great. I recently spent about 5 hours over 2 days in our Whatcom call center observing. And I'm just wondering how 988 should work with our call center. Any thoughts you have? What's the best integration? What kind of load can it take? I see that you have was it King County or Pierce County where you have somebody from 988 in their call center? Give us some best practices. What would it look like here in Whatcom County?
Yeah, absolutely. So I can speak to that. I assume you're talking about the Whatcom County PSAP, the 911 center, call center. That's where you spend the time. Yeah. So that's really our goal, to expand this diversion program to all of our service regions. So Snohomish and Whatcom are kind of our next hopes for where we might go. But as far as best practices around that, so it is currently possible to transfer calls to 988 from 911. We would be happy to collaborate with you on best practices around that, around a specific criteria. And on our end, of course, we'd work on a criteria for what warrants a call going back to 911, because we have seen that happen in certain situations of imminent risk. So I'm happy to talk with you more about that. But essentially, if you identify a call that there's a suicide or mental health component, but there's not imminent risk, it's more resource oriented in nature, and you want to be able to hand the person off to a response that maybe can spend more time navigating what the need really is, and maybe they don't need a law enforcement response, they don't need an in-person intervention. That's the type of call that could be warm transferred to 988. Some things I just want to be transparent about, calls are routed based on area code. So we would just have to ensure that dialing 988 actually gets you to the right 988 center, being us. So that is something the state and federally is working on, geo routing, not geolocation, but actually just being able to route calls to the nearest 988 center based on where the call is coming from. Another thing we're working on the back end that we're looking to Department of Health to inform for Washington State is a terminating number that would bypass that IVR. So you wouldn't have to sit through the 5 options when reaching out to 988. And that would save a little bit of time, because I know those 911 call takers calls tend to be, the average of 30 seconds or so. And we don't want to add, I know every second counts in that type of work. So that's something that more to come, more stuff in play that's going to actually come out and be officially the best practices for the state. But in the interim, I'm happy to work with you on that.
I want to follow up on that just a little bit on Peter's question. So Bellingham and Whatcom County have what's called an alternate response team, and we worked on that based on the Whitebird Clinic in Eugene, Oregon, and then some other models out of Portland, Denver, and Albuquerque. And the idea is, instead of sending a law enforcement officer with a badge and a gun to a behavioral health call, we send designated crisis responders. And when we first when we began this program, we sent a nurse as well, but I think we changed that to 2 DCRs that would go out and respond. And so I guess my question is that so when a call gets fielded by Whatcom, which is our call center here, and it's clearly a behavioral health call, it would go to the Compass health worker. That's the contracted agent, 8 hours a day, 5 days a week. And then those DCRs would get deployed. And so what I'm trying to figure out is how do Volunteers of America, how does this program, the 988 program, work with when there's a local program in place? How does it work in conjunction with that? And yeah, I guess that's my question.
Yeah, that's a great question. And we have a similar thing in Pierce County. We have the DCRs that will respond to certain behavioral health situations. And then we also have things like the HOPE team, which is, I think, kind of what you were talking about with having nurses respond to. So there are some similar situations in Pierce County, and we work really collaboratively with the Behavioral Health Administrative Service Organization around what protocols already exist for referring to these different teams, and then we'll try to streamline those as best we can. We also work within the 911 system if they have protocols already in place to send those calls elsewhere when there is an in-person response required that's behavioral health in nature. So we'll kind of just refine those protocols and see what makes the most sense and has the least amount of impact on the community. I will say, from our diversion efforts at South Sound 911, we see that over 90% of the calls are actually resolved on the phone or through referrals to our follow-up services, and less than 10% actually require an in-person response. So it could be, we just have kind of a more broad scope in that sense, and then we do refer collaboratively to those teams that do the in-person response as needed.
Thanks, Courtney. Melora?
Yeah, thanks, Dan. I just wanted to clarify a little bit about the alternative response team and what we have at our Whatcom Center and how it interacts with this conversation. So we actually have an embedded community connector that's part of the alternative response team, which is different than a 988 clinician. And they are actually dispatching the alternative response team, which is made up of behavioral health specialists. So we don't actually have DCRs on the alternative response team, but those are behavioral health specialists. And then when the call actually needs that level of support, then we're working with Compass Health and the VOA to dispatch the DCRs. So there's a lot of triaging that happens within that system to figure out. And listening to this conversation, I think that there would be a really great collaboration with having a 988 clinician in addition to the alternative response community connector, because as Courtney said, they're resolving issues on the phone. That's very different than what the community connector does, which is dispatch community teams as an alternative to law enforcement. So we could actually have both, but it's just, it gets a little confusing with all of these different programs. So I hope that is helpful for folks.
Thanks, Laura. That's very helpful. Yeah, I was just out at a large retailer last week, and they were asking, if a retail associate encounters somebody having a behavioral health crisis, what do they do? So I'm just trying to get that clarification when I talk to my constituents that I'm giving them the appropriate information. Go ahead, Mike Parker.
Thanks, Dan. Thanks for the presentation. All it's really helpful. A quick follow-up question. So based on that it's area code and that you're not getting geolocation of the person's physical location at the time. I mean, somebody with an out-of-state phone, but living in Washington State, and many people are keeping their phone numbers from, previous places. Can you tell me how that call would be routed?
Yeah,
Yeah.
absolutely. So it would end up coming to us if they have a Washington area code, and it does happen all the time where we will speak to someone that's in New York, and they're coming to us. So I guess kind of the process of that call, if we are able to discover like, oh, you're not in Washington State. I mean, first we're going to safety plan with them and build rapport and that sort of thing. But then next, there is going to be a focus of trying to connect them to somebody in New York, and it's usually going to be a local crisis line that we're going to direct them to. But that does happen quite often because, like Courtney explained, it's not geolocation; it's based solely off the area code. So that does happen.
Right. I also had another follow-up question. I think you touched on this a little bit, but how you work with, a DCR. So obviously a person reaching out for support, during a crisis, especially suicide, is a big risk factor. And there are some people that may be calling you who may be on like less restrictive orders. They may have some pretty intensive services on board. And I'm just wondering if you might touch base a little bit on two topics around that. One, how would you connect that person? Do you have access to that? The old system, sometimes people could get into Raintree and try to find information about what a person was doing. Obviously that continuity, I guess, is what I'm getting at. How do you work? And then the second piece is how do your clinicians work with DCRs in the event that, that DCR is collecting affidavits? Can that call, the subject of that call and that conversation be helpful in getting that person seen by a DCR, or possibly if they need to if they need to be involuntarily committed, maybe you could talk a little bit about how your clinicians work with that.
So right now, the way that 988 is set up in Washington State, it's still two sections of who works with the DCR and who doesn't. So right now in Washington State, it's the regional crisis lines that are doing the work with the DCRs. So that information is stored in their system. Now, it just so happens that at VOA, we operate some of the regional crisis lines. So we do have access to some of that information, but not all information across counties. So as far as like getting access to a DCR through 988, it's going to be a referral that we do. So again, we're going to gather information and then we're going to pass that information, either give the kind of explain to the caller how to access to a DCR through the regional crisis line, or even do like a warm transfer where we then give that information to the regional crisis line so that they can make that connection together. But just because of how the system is set up currently, it's still two separate parts, which is, it can be a little bit frustrating. I think that we're kind of working in the direction of everything becoming one, but we're not quite there yet.
Brian Estes?
Does it, and just really fast, does that happen
go ahead, Mike.
automatically? What you talked about that connection, let's say that it's not an area that you serve, right? With, that VOA serves in the regional crisis line. Is that an automatic thing, or would other interested parties, either the caller themselves or maybe their mental health clinicians, have to request that connection with the local DCR? And I'm sorry, I'll stop asking questions.
Sure, it would be pretty automatic. If they're, when somebody calls and is looking for resources, especially, I mean, one of the first things that a clinician is going to do is start to research the local crisis line in their area, because right now in Washington State, that's the best way to access it. Direct resources, in person, DCRs, MCOT teams, that sort of thing, is through the regional crisis line. So that information is going to be provided on most calls if the person is looking for it and willing to receive it.
Good questions, Mike. Sorry, I didn't mean to cut you off. Brian Estes, go ahead.
Yeah, just to clarify real quick in terms of staffing, a number of the options that you mentioned, Reed, such as the veterans and LGBTQ, are not operated by your organization, right? Could you just talk briefly about that? And then my second question might be for Courtney. As you know, the legislature every year for the last few years has several 988 bills, and we're working on resolving some of the issues that we've been discussing here. Could you talk a little bit about either SB 6308 or SB 6251 related to the ASOs and kind of communication within their jurisdictions related to crisis response?
Go ahead, Courtney.
Yeah, so I might have to check on that and get back to you. I know especially SB 6251 is one that's going to be pretty impactful for everything we do. I think the goal and the vision right now is that not much will change in the actual 988 system, but what it might do is expand to other regions to give more region-specific support. So that's something that overall will be a good thing as far as we're concerned, but what it will actually look like, little above my pay grade, but I'm happy to look into it and send out some more information for reference.
And Reed, could you talk about the staffing for some
Yeah,
of the,
so for the other two options, those are staffed by crisis centers that I believe, and Courtney might have to help me clarify, that are located outside of Washington State, for the Veterans Crisis Line and for LGBTQ. And those are usually kind of more national centers where those calls are routed to. Again, though, I mean, and I can't speak for other centers, but the process is going to be very similar, where information is gathered and those people are going to be directed to local resources, you know, whether it's calling a local crisis line, whether it's being transferred to a local 988, where things can kind of be looked into in a more just specific manner, as opposed to just providing general resources for things.
Yeah, I can expand on that a little bit. Thank you, Reed. So all of those population specific options, when someone calls 988 or when they text or chat with 988, those go to what Vibrant, the organization that runs the Lifeline and routes interactions, those are referred to as subnetworks. So we do at Volunteers of America, we cover 1/4 of the nation's LGBTQI plus youth chat and text subnetworks. So we're familiar with that and how that routing works. As far as staffing levels, we don't have a ton of visibility into that, but what we can see is that the answer rates for nationwide for these different options through 988 are typically around or over 90%. So it's roughly kind of the same amount of time it takes to answer the call, and then referrals to regional resources are pretty definitely emphasized in these programs. There is in the unified platform that's used for a lot of these interactions where they're routed to, there is a resource bank that contains a lot of local resources. Local centers have a lot of agency over what resources to input into those that then become accessible to other centers in the national subnetwork. So that's something that definitely is being built on, but a consideration that's been a topic of discussion for a while.
Okay, Melora.
Yeah, thank you, Dan. So I guess I have, Dan, to your point of, meeting with community members or businesses, and they're like, who do we call and what do we do? And right now, I mean, we have a trifold document, right? That is so extensive that you have to give someone a trifold document to try to think of who they should call. And so in all of the things that are being built on, is the goal long-term to be able to tell a community member, call 988. If it's behavioral health, call 911. If it's an emergency and you think you need, medical or law enforcement, do you think that's, I know it's very complex, but that simple structure is where we can get to as a state?
100%, yes. And I mean, when you guys are talking about like who should call 988, the answer is everybody in every situation. Even if it's an emergent, I mean, obviously it's immediate threat to life or death, to 911, but if whether you are a third party, and I want to let Courtney, if Courtney needs to get out of here, I know that Courtney has another meeting to go to. So, but whether you are a third party, whether you're concerned about yourself or anybody else, you can 100% call 988, and 988 can direct you. Even if it's not the right now, if it's not the direct access point to a specific resource, we can absolutely connect you to that direct access point. So it is 100% the first place that people should call.
Yeah, just to add to that, thank you, Reed. I think the community education around what 3-digit number to call or what resource to reach out to, that's really important. And then another thing simultaneously behind the scenes that is important is doing our best we can to create a no wrong door approach, so that if someone calls, the number that maybe it wasn't the best response, the community member won't feel it on their end, and we can have streamlined processes for how to get them to the help they need, how to support each other's efforts, and just create a really integrated community crisis support network. And I do have to hop off, but please, I'll throw well, I don't see the chat, but my email should be somewhere. So please feel free to reach out to me about anything diversion specific, especially, and thank you, everyone.
Thanks,
Thank
Courtney.
you. Dr. Wu, thanks for waiting patiently.
I just have two quick questions. One is, I think I heard someone say something about the average length of time that the call takes with in response to 988, and I didn't quite catch if that was the time to get into the system or if that was the actual length of the call, because it sounded really short to me. And the other is for Whatcom County, when you are looking for resources to refer to, what are you finding and how is that going?
Sure. So I'll give you the answer, the first part of the answer for phones, and then I'll let Caitlin tell you what the time is for chat and text. But so I think maybe what you heard, as I said, it takes about 30 seconds to get through the phone tree. And then we answer 988 calls on average in about 12 seconds. So I would say, you know, from time of dial, if you listen to the entire phone tree and then being connected to a counselor, it's anywhere from 20 to 40 seconds maybe. And anything over that would be in an outlier, I would say. You know, if all of our lines are busy, calls can flow out to other systems. Sometimes that takes a little bit longer, but usually between 20 and 40 seconds. And then as far as like actual like talk time of a 988 call, I would say on average between 10 and 25 minutes would be the average talk time of a 988 call. But I'll let Caitlin give you the answer for chat and text, and I'll answer the second part of your question.
It's similar for chat and text. It's about 20 to 30 seconds from the second that they either initiate a chat on our website or send a text to 988. They do have to fill out a pre-chat survey, or they're asked to for some demographic information. If they're on the chat, they will put in a zip code, which will route them to our center if they do put in a Washington zip code. And then our interactions last anywhere from 30 minutes to an hour. We try to keep it at the 45-minute mark if they're not imminent. And, you know, at that 45-minute mark, we will kind of reassess and, if necessary, give the FUS program an opportunity to try to help the client out a little bit more, depending on what kind of services they're requiring.
Thanks, Caitlin. And then as far as resources within Whatcom County, it can be difficult, you know, because we are operating across the state. So, you know, we're trying to kind of find and locate resources within each county. I think with Whatcom County, what is really beneficial, like I said earlier, so at VOA, we operate the regional crisis line for Snohomish and Whatcom County and North Sound. So there is a connection, you know, definitely between 908 counselors and regional crisis line counselors that just kind of happens naturally, even though we are all remote. We have Teams chats and stuff where people communicate. So there is some, you know, kind of back and forth of information that gets shared there. We utilize the regional crisis line a lot. We utilize, you know, being able to offer like MCOT and access to DCRs, and again, kind of explaining that process to people and how to access them through the regional crisis line is something that happens quite often. So yeah.
Doctor, does that answer your question?
Yeah, thank you.
Great. Brian, then Melora.
I just wanted to say I would following up on kind of Peter's comment about, you know, best practices integrating 988 to 911. I would be willing to follow up with the appropriate Whatcom County, you know, 911 center to hook them up with Courtney and begin that dialogue. I think it's important that we not let this opportunity go by. So that's all I had to say.
Thanks, Brian. Melora.
Yeah, thanks. I just wanted to speak to Dr. Wu's question about local resources. I think one of the things that we're finding with having a community connector embedded at the Whatcom 911 Center, who's a local service provider and part of the alternative response team, they do 50% of their time at dispatch and 50% of their time responding to 911 calls. And so having that embedded expert on how to access services has completely transformed the way that dispatchers at Whatcom understand and interact with services. And Director Everbeck from Whatcom 911 would be a great person to be able to share what we're seeing just in the first pilot year of that project.
Very cool. Yeah, I'm excited. The South Sound, what we've done kind of with the co-location is what I call it. I think we go back and forth on whether to call it co-location or crisis diversion, but what it's been able to do in a very short amount of time is very cool, and it just is kind of a very like revolutionary thing that's occurring. That is, you know, to be able to take some of these people that are repeatedly calling 911 and are in mental health crisis and have them actually work with somebody that has, you know, the time and the ability to actually sit with them one-to-one for a little bit has been very cool. So yeah, I'm excited to see it grow and continue to kind of branch out.
Harry.
Hey, Reed, Caitlin, thank you so much for the information and all of the detail. I was just curious, you know, you said that you were working with somewhere around 45 staff. Just relative to, I'm sure you're, you know, thinking about it and responding to it, but vicarious trauma for the individuals. It sounds like folks are working remotely, which is awesome that we have that kind of resource and can use that. And at the same time, old clinical supervisor, you know, not being able to connect with people in person, you know, and that sort of thing, and supporting them in what's got to be a super challenging in an ongoing way, you know, process for individuals, et cetera. So just curious about that piece.
Yeah, it is that's a really good point. It is I would say it's something that I'm really passionate about. So I've been with VOA for about 7 years. I started as one of the first like lifeline call takers back in 2016. And so, you know, I've kind of come up through the system, so to speak. So I have a really good understanding of how hard the job can be, and, you know, the type of person that it takes and the type of toll that it can take on a person. So I view my role as, you know, somebody who has to try to figure out how to get people to be somewhat comfortable in this job so that they can stay. I have a personal philosophy that like there's only so many people in the world that can do a job like this. There's fewer that can do it for a long period of time, and there's fewer than that can do it for a long period of time and do it well. So it really is like my goal essentially to figure out how do I make you comfortable and support you in doing this. And so it's something that, you know, we're constantly evaluating and talking about and trying to think about how to make processes more efficient, how to try, you know, how to make things easier, how to make things more comfortable. But the remote piece is a hard piece to tackle because this is a job that just by itself, it can make you feel like you're on an island, you know, when you're talking one-on-one with somebody and it's a life or death situation. And, you know, that's stressful, and it feels like it's just you and that person and you're on an island. So doing the best that we can to support people in the moment. You know, we've staffed up a lot. We have shift leads that kind of are in charge of like chunks of five people, essentially shifts of 5 people. So that's a really big aspect of providing like in the moment support. But it is definitely, I think it's one of those things that just kind of this continuous conversation of how do we make people more comfortable and be able to do this.
So I want to wrap things up here a little bit. We're a little over time, and we've got some other agenda items to get to, but I did want to recognize Arlene. She's got her hand raised.
Yes, the services that are being offered are wonderful, and the crisis center is going to be face-to-face that we are building, but it will take time, and this is here now. So we are going to make use of it, but it is the same as the crisis center.
Mm-hmm.
Yep.
I think
okay.
Kind of as Brian alluded to early on, there's 3 parts of the 988 system that the federal government is trying to kick into action. The first part has already been initiated, and that's someplace to call. The second part is someone to come out to you, which again we have, but it's 2 separate entities, kind of like I explained. The third part is having somewhere to go. So it's a long-term process. It's a long-term thing, but eventually I really do think that we'll see everything under some sort of one umbrella where everybody interacts with each other. It's a work in progress.
I think based on the amount of questions, it's pretty clear that there's a lot of interest in this kind of response. So I really thank you both for coming, and Courtney as well.
Absolutely.
Yeah, absolutely. Thank you. And Brian, thanks for organizing this. This conversation will likely obviously continue, but thanks for giving us this overview. We really appreciate both of you.
Thank you, guys.
Thank you for having us.
Yep.
Have a good rest of your day.
Okay, thank you. Take care. And Raylene, or actually Jill Nixon, can you put up the agenda real quick? Okay, looks like we have, I think I'm gonna turn it over to Raylene. I think this is, she's got this report along with Stephanie Kraft.
Thank you. And I just wanted to say thank you, Brian, Caitlin, Courtney, and Reed for that presentation. It was very beneficial and will help us move forward and not backwards. And speaking of changes and moving forward, Stephanie Kraft and I are here to present on changes to Whatcom County Superior Court. And I was appointed the county clerk position in November, and Stephanie was selected to be the Superior Court and Juvenile Court Administrator. Our predecessor was Dave Reynolds, so we both have some big shoes to fill, but we're working really hard at doing that. So for many years, Whatcom County's court administrator and county clerk was one person. And there was a ethics advisory committee opinion from the state of Washington prior to Stephanie and I coming on board that wanted to make sure that we were doing things right along with the judges and the executive branch, to make sure there was a clear separation of powers. The judicial branch and the executive branch both want to promote public confidence and the independence, integrity, and impartiality of the judiciary branch, as well as making sure the clerk's office remains neutral. So the clerk's office is under the executive branch, and that's constitutionally found in section 11 and 4 of the Constitution on appointment and elections of public officials in the county clerk's office. So under my role, the clerks are maintaining the records. The county clerk is an official who maintains the official records of Superior Court cases, oversees all record keeping pertaining to those cases. And we also work with assigned counsel. So assigned counsel is under my office. So when somebody screens for a public defender, somebody in my office does that screening and then routes those individuals to the public defender's office or conflict attorneys to make sure those people are adequately represented to the best of our ability. And we also have a family law facilitator. Family law facilitators do not give legal advice, but they make sure they help people with the process of filling out forms, whether it be divorce decrees, parenting plans. Essentially, they are making sure that the I's are dotted and the T's are crossed without giving legal advice. Those processes assist in people getting through the court system more efficiently, as well as not having so many court hearings because there was a couple steps missed before they got to court. So those are important roles that we fill. As most of you have probably had to do some type of American government, there's the executive, judicial, and legislative branch, and we're kind of like an egg. There's the shell and the yolk and the white, and we're not supposed to scramble each other, but we all have to work together. So that's what we're trying to do, is make sure we're doing it right. It is a legal separation, so doing that's going to take a little bit of a process between Stephanie and I, as we've got budgets that need to be separated, personnel that needs to be separated, making sure people know who to ask for and to get the help for, so they're going to the right players. We're involving IT, we're involving human resources and facilities and lots of different facets of this. So it's going to take us a little bit of time to get through all of it. The minor guardianship facilitator is also a very important role. Some counties have that under the clerk's office, and some counties have that under the administration. We're trying it under both, but there's not enough of us to go around to effectively support that role, but we're doing our best to try to see how we can work on that. But right now, Stephanie has staff that are trying to share and fill in the gaps. as much as possible to assist with the minor guardianship facilitator. But I'm going to turn it over to Stephanie, and she will explain her role and what she does, and then we'll open it up for questions.
Hello, everyone. I'm Stephanie Kraft. I'm the Juvenile and Superior Court Administrator. So for my role, I oversee all of juvenile detention and juvenile probation, recovery courts, pretrial services, and do the function and look at the functions of the court, such as scheduling interpreters, maintaining GAL registries, making sure that we have the appropriate equipment in the courtrooms. We're responsible for ensuring scheduling of judicial officers to cover cases. We would respond to GR 33 ADA requests. All of the employees that are part of our branch are GR 29 employees, so the court really directs our work. As Raylene said, there's a lot that's going into separating these two departments that have long been one department. In addition to separating the budget, it is making sure we have the staff to continue fulfilling all of our duties, and that's been a little bit of a slow process. So there are still a few things that we're unwinding, and in the interim, things that we're sharing to ensure that there's not a break in service and that things continue to go smoothly for folks.
Courtney.
Oh, sorry, I couldn't get my mic unmuted. I have a question for Stephanie about juvenile detention. I'm just curious what your thoughts are on, we've had a lot of juvenile clients that really wish there were groups offered. And I'm wondering what your thoughts are on incorporating some DBT curriculum or just something more evidence-based. What shifts are happening with clinical services and detention?
So we do offer groups. We do not currently offer a DBT group. That is actually something that we're currently exploring, specifically training for staff so we can be utilizing those skills in our interactions with the youth, maybe cueing them so that they're learning how to do things like one of the skills might be urge surf. And when they're feeling overwhelmed in a situation. So if there are interested groups, I'm willing to hear from folks about that and work with our detention manager. We have AA groups that come in, Lifeline comes in and provides services. DBSAS has provided some services. There's currently a poetry group and a music group and a church group. So we're happy to explore other options.
Thank you.
Thank you, Stephanie. Does anybody else have any other questions for us? Well, we must have done a great job, Stephanie. Well, we are going to go on to the next item on the agenda, which is brief committee reports and project updates. The first item on that is law enforcement drop-off at the Ann Deacon Center for Hope. And I believe Dan and Mike can take it away.
Yeah, I asked Peter Frazier to give us sort of a synopsis. We asked him to facilitate that part of the meeting. And so, Peter, are you prepared to do that today?
Sure. Yeah, I'll give a little update for those of you who weren't in the last behavioral health subcommittee meeting. Dan and Mike had asked me to report on two things. One was Ann Deacon Center for Hope as far as law enforcement drop off. And the other item was an update from how far the county has gotten with the implementation plan. So The vast majority of our time was spent, instead of my giving a report, we had a good, robust discussion about the Ann Deacon Center. We had representatives from law enforcement and EMS there. We had service providers and folks from the health department there, and we discussed the gaps, I guess we could say, gaps, barriers, disappointments, difficulties, successes, and it was a really good discussion. I hope everybody found it to be so. It was, I think people were speaking frankly, unearthed various process issues, and I think some of them will be able to be resolved. Kind of the lower level issues can be resolved there at Ann Deacon Center. Kind of the medium and high level barriers are going to be more difficult. I read the report that Brian actually flashed up on the screen there briefly from SAMHSA, the National Guidelines for Behavioral Health Crisis Care Best Practice Toolkit, 80-page report. I recommend that everybody read this. It shows how well we have done in some ways to put together a good crisis care system here in Whatcom County, but it's not operating with the no wrong door philosophy. It's just not operating that way. We have obviously design of the 23-hour crisis center coming up, and it's greatly needed. And so anyway, review that meeting if you're interested in the details around what we could do better and what we're going to need to take on with the 23-hour crisis center. Then also, I gave a very brief synopsis of where the county is with the implementation plan. I think, is Barry on this call? Is he going to be speaking to that? Anyway, my report was sent out, I believe, to everybody. So that is, that's what I covered. And did I see Courtney? Did you have a question or a comment?
I did, just about that meeting, like thoughts on what we could do next time if we have another meeting like that. I would love to see more frontline behavioral health staff. We need to center the voices of the people doing the work and the clients. And I say this less about this meeting, but just several events in Whatcom, I've noticed they tend to center the voices of law enforcement. Law enforcement are not the only people doing this work.
Thank you, Courtney. Dan, back to you.
Okay, I think that concludes the Behavioral Health Committee report. And so back to you, Raylene.
All right, so excuse me, because I did have to step away for just a second, but I think the next would be the Justice Project Implementation Plan by Jill Nixon.
Good afternoon, everyone. I want to give Stephen, as a member of the Justice Project planning team, an opportunity. Do you want to speak to this, Stephen, or do you want me to just go through my quick list?
Yeah, the planning team is really sort of getting its feet on the ground and sort of wrapping our arms around a number of pieces that are just beginning to start. So Jill, I think for this month, it would be useful just to go through your compilation of notes on those discussions.
Okay, I'm happy to. Just a couple of things. The scope of work for the facilitator for the Justice Project Planning and Oversight Committee is being worked up, and I think it's fine. We finalized that that scope of work, and we'll be going out for an RFP soon. The facilitator for the JPOP committee, if you recall, is going to be a new subcommittee of the full task force. The facilitator for the JPOP committee will seat and provide all administrative support to the committee. The facilitator will also help the new IPRTF co-chairs facilitate the full task force meetings. They will attend the steering committee and the Justice Project Planning team, and they will also provide written updates to all of the other IPRTF subcommittees on request. The facilitator will liaise with the county executive's office on the progress of each of the implementation plan's 15 projects. They will be in charge of writing the task force annual reports, and they will create a very general tracking process and report for each of the 15 projects that will go up on the county's website for the public. And yeah, so those are the major duties of the facilitator. Regarding the JPOP committee, there are 9 appointed positions that we're in the process of assigning people to right now, and 12 permanent positions for current IPRTF and other members that we'll be talking about in more detail at next week's task force meeting. And that's all I have.
Thanks, Jill. The next one is a report from Perry Mowry on competency restoration work group.
Afternoon, folks. Wanted to provide an update on the competency restoration work group that has been in existence. I'm going to guess here a little bit, about 18 months or so, meeting on a monthly basis virtually at this point. We have some competency restoration work group members actually here with us today. Generally, the group is made up of judicial officers, the prosecutor's office, public defender's office, county council, behavioral health subcommittee members, as well as citizens, knowledgeable citizens that have a voice, challenges and issues that need to be addressed. If it isn't evident, generally speaking, this group convened to take a real close look at the challenges of individuals that have or are identified with serious mental illness and the possibility of a need for competency evaluation / restoration, and the lengthy period of time that they remain incarcerated in the jail due to limited services and availability of resources from the state, Western State Hospital, Eastern State Hospital, the evaluators, etc. So what we did, just super generally, I've got way too many notes here and don't want to bore folks, but what we've sort of reviewed information on and tried to to sort of capsulize within this group was the basically 4 options. Essentially, in other counties, there's some activity going on, and so we sort of looked at those and gathered information and etc. One option was really the prosecutor's office dropping low-level charges for individuals that, again, that I was describing that may have a competency restoration evaluation needs, etc. The challenge there, of course, is an individual simply being released to the community that has a serious mental illness, maybe incapable or unwilling to engage in the limited services that are available in our community for individuals that struggle with this level of mental health issues. Obviously, another option is some individuals are referred successfully to Western State Hospital if they're evaluated as needing competency restoration. One of the things that I always clarify with this, that's not always obvious to everybody, it certainly wasn't to me as we started this process, is that competency restoration is really about restoring an individual to a competency level of where they can understand and assist with their charges, as opposed to, it is oftentimes misunderstood that competency restoration really is about addressing behavioral health needs. And so there is definitely a distinct difference there. So I would consider that one of the challenges with referring individuals to Western State Hospital. One of the other things that's really stuck out to me as well was individuals obviously that are appropriate and referred, go to Western State, Eastern State Hospital. and then return to incarceration in the Whatcom County Jail. Sometimes those individuals will at that point refuse medication or the recommendations that had been established while they were at Western State Hospital, and the individual then fairly quickly decompensates during the time that they are then reincarcerated. So sort of a revolving door process that can occur there, obviously extending the individual's time in incarceration. The other option that we looked at and discussed some was developing an assisted outpatient treatment program. If folks aren't familiar, AOTs are really behavioral health oriented programs to support individuals, meet with them regularly, address behavioral health needs, obviously medication, communication with a trained clinician, that sort of thing. There are a very limited number of AOT programs in the North Sound region. Interestingly enough, our Behavioral Health Administrative Services organization was charged with the responsibility to develop outpatient assisted treatment type programs. And so they reached out to providers within the North Sound region. Very few were feeling like they were at a capacity that they could take on that additional and obviously challenging role in an outpatient setting. One program in Snohomish County tossed their hat in the ring and is developing, as I understand, at this point in time, but there were no providers within Whatcom County that had expressed a willingness to develop an assisted outpatient treatment program at this point. So some information about that. It is, I will say that some of the input that we received as a group was that the assisted outpatient treatment programs would probably only meet some individuals' needs as far as individuals that are incarcerated or have that level of serious mental illness and are dealing with judicial systems, because the individuals are affected enough by their serious mental illness that an outpatient setting might not actually be beneficial for them. I didn't leave this for the last intentionally, but we spent quite a bit of time also on the possibility and development of a prosecutorial diversion program. There are actually several of these programs. Well, I'll say several. There's 3 of these programs currently in existence in the state of Washington. They were funded through the True Blood funds. They're located in Spokane, King County, and Franklin-Benton County. We actually had an opportunity as a group to sit in on the I think it's a quarterly meeting of those providers with the Office of Forensic Mental Health Services. The OFMHS, if you will, actually administers those contracts. And so it's pretty interesting to sit in on those and just, at least for me, to hear from a provider standpoint of, hey, what's working? How successful are you? What are some of the challenges? Et cetera. So we've gotten a little bit more information about that. We've actually taken this idea of the prosecutorial diversion programs, or PDPs, if I can shorten that, and taken a look at funding and some other components, the possibility of developing a PDP in Whatcom County. We went so far as to actually develop a draft, I'm going to call it a draft funding process with the Office of Forensic Mental Health Services, of where we put together a draft budget, essentially based on a PDP structure that they had made as a recommendation for what they feel like works best in most of the programs. We actually submitted that to the Office of Forensic Mental Health Services, not as a commitment to provide this service, but essentially they had gone to the legislature, were asking for funding, and were interested in getting a sense from various counties that had interests in providing a PDP in their county of what the cost of that might be, estimated costs and so forth. So we went through that process. I actually submitted that back in November. Unfortunately, the work that the Office of Forensic Mental Health Services had done with the legislators, the governor's office didn't receive specific funding for that, although the Office of Forensic Mental Health Services has pursued proviso dollars for expanding prosecutorial diversion programs in the state. And I think we all know that the legislative session just recently ended. I've been in a little bit of communication with the representative from the Office of Forensic Mental Health Services, and he indicated that he'll get back to me as quickly as he can with what the outcome of that was and what the recommendations relative to funding from the Office of Forensic Mental Health Services are. They again provided us, the OFMHS provided us with a structure for these programs. I won't go into that just to save time, but you can imagine that it, obviously included someone that can prescribe medications and mental health professionals, case managers, etc. So that's what the budget that we had submitted was based on. From there, more recently, a couple of pieces that have popped up. We have been in some communication with Disability Rights Washington, the office of in Seattle area, I believe, relative to the possibility of funding. The group has been very focused, understandably, on the need for housing relative to individuals that we're trying to support and help. It's great to have behavioral health services and those sorts of things, but many of these individuals obviously struggle with homelessness, and so that's a significant component of what we're taking a look at. We have the executive's office had actually made contact with the Office of Disability Rights Washington relative to funding that is coming available through the True Blood process. At this point in time, a fairly extensive amount of funds, at least reportedly, are going to become available. And the distinct possibility that those funds might be usable for a housing kind of process and so forth. There's an RFP that's going to be released by the Office of Disability Rights Washington. It looks like in April, and the executive's office had already submitted a letter of interest in that regard. So more to be discussed along those lines. Additionally, and somewhat ancillary, there has been an entity, AA Health Services, that has expressed an interest in purchasing an existing nursing facility in Bellingham. They have a rather interesting and different model in the programs that they provide services to and through in California. The nursing facility is a 132-bed facility. Their model is to provide nursing support, skilled services for individuals with serious mental illness. And they do so by charging the local government or state, or however it ends up working within the contract, for a per bed per day amount, as opposed to billing Medicaid. So we're doing some additional research and information in that regard because the bed cost that they had provided a general outline for was about $250 a day, which of course brought a sticker shock. But when we consider that housing an individual in the jail is somewhere around $208 a day, that sort of levels that whole process as well. It is a 132-bed facility, which may be beds beyond what the need for Whatcom County would be. That's to be determined. But some of the other models have been in counties actually reaching out to other counties and other counties taking on the responsibility for X number of beds and the cost of same, so that they can use those, et cetera. So that isn't fully developed at this point in time. There's still a lot of information to be gathered. We've had some interaction and communication with health professionals in the San Francisco area that are working with this AA Health Services company, and gotten some feedback from them in terms of the interaction. They do have a large contract with the San Francisco area health department, and so got some feedback from some folks, kind of counterparts, if you will, of ourselves, in that regard. And so I believe a visit actually to the facility has been arranged by some of the staff. So more information to be gathered there. And obviously, this could be a pretty significant component and resource, or even an alternative, if you will, to the prosecutorial diversion program kind of concept and idea. That was a lot of information really fast. Hopefully I wasn't, talking too fast at that. Maybe I'll stop there in terms of updates. We have our next meeting this Friday, actually, and to just develop some of these points to further discuss with the other great and smart folks that are a part of this work group.
Thank you, Perry. I see Courtney's hand raised.
Yeah, I wanted to circle back to AOT because that was a lot of information, and I don't want AOT to be glossed over. It's a really great resource to know about. We don't have it in our community yet. I really recommend looking into the treatmentadvocacycenter.org. So just offering a resource plug. There's a lot of great data on there you can look at it by state, and you can learn about AOT programs nationwide. So that's the treatmentadvocacycenter.org. Thanks.
Thanks, Courtney. Does anybody else? Oh, I see Mike Parker's hand up.
Hi, thanks, Raylene. And Perry, as always, thank you for the thorough report. That's really helpful. I'm always chagrined that I'm not able to make it, but your reports kind of cover me, and I appreciate that. I had one question for you. Is that group receiving information and or interested from a dashboard like style from what is the backlog looking like? And I think that was one of the things that helped the task force realize that this was something of great import, is we would get some details about how many folks in Whatcom were actually waiting, right, to have competency restored or to be evaluated, and all those pieces. So if you could speak to that, any thoughts about data? Do you track that? Are you seeing, like the state is saying that these wait times are getting better? I'm just curious if that is an element of your committee work.
Yeah, I don't have the specific detail in front of me, but actually, Prosecutor Ritchie reached out to Disability Rights Washington, and there is actually a website, relative to that. Interestingly enough, in the past, I'm not sure if I'm going to state the time frame correctly. The past 6 months, there's seen a significant improvement in the wait times for individuals needing competency restoration work to about 20 days, as opposed to, I think that everybody here is probably familiar with the 180 days plus that has, historically been an issue. There's a question about whether that's sustainable at this point relative to the state, but that there have been some improvements there. Also, it's interesting because I have sort of reached out to historically Wendy Jones, chief of the jail, obviously Chief Erickson now in that place, and gotten some more specific information just regard to, the Whatcom County Jail. And, what I've found is that it tends to be divided into different pots. That is, individuals with lower charges, kind of thing, and individuals with much more significant charges. And so, those numbers have tended to vary. I have not reached out recently and gotten that information, but Chief Erickson is actually a member of the group, of the work group, and hopefully as he gets settled into the chaos that I'm sure his work is, he'll be able to attend more regularly and give us updates. It's been really valuable.
Thank you, Perry. And as a side note, Perry did reach out to me. I am still kind of working through data on what the impacts are on Superior Court. And I'll work with Stephanie and AOC on that. We're still learning some different sections on that. There's so many different impacts with competency and restoration, where individuals that are not incarcerated have to rely on outpatient programs and evaluations, and those waits are a lot longer, and a lot of times we see them back into the being incarcerated. Some individuals, as you mentioned, deteriorate once they've gotten restoration and they refuse to take medication. There's also changes of defense counsel throughout time as they're waiting for restoration and they come back. I'm sure Courtney can speak to that. So there's a lot of different impacts, but I will do my diligence to try to get you more data on my end, Perry. So I just wanted to let you know. And Courtney, I see your hands up.
Yeah, I was just gonna offer a little more context on like our side of dealing with the restoration system. I mean, there's nothing not complicated about working with the restoration system, but another layer to this is that sometimes you have clients, I mean, depending on who you're working, most of my clients, they're navigating all three courts, Superior Court, District, and Municipal. And, I'll just give you the example of a client who, they had a competency eval in Superior Court. They were opined competent, but then they were evaluated by someone else, still under OFFMs, but through municipal court, and they were deemed incompetent. And so that also causes issues too, when there's disagreements between evaluators on different court orders, and there's different lengths of time for restoration depending on the charge classification. So felonies, you're looking at, 90 to 180 days. Misdemeanors, it's the 29 and under. And now they're, trying to adjust that now even more, and it needs adjustment. But also again, I just want to remind people that it's not just that people are refusing medication. Yes, that is the case sometimes. It is not the case all the time. Many times when people are in the jail waiting to go to Western, they decompensate and are not provided the medications they were stabilized to begin with. And there is not great communication between Western State Hospital and the clinical services in the jail. That's why me and Nathan exist, among other reasons. So there are a lot of layers to the system, and people are waiting a very long time. And one of the biggest things that would be a huge help is if prosecutors were willing to dismiss charges, or if we had a diversion program, because people should not be spending years in jail and at Western in the restoration system for very minor alleged crimes.
Thank you, Courtney. I don't see any other hands up. It is 1 o'clock. So I think I need to open this up for public comment. And I'm sure the competency and restoration process will continue throughout our meetings. Jill, do you have anybody in the public?
Thank you. If any of our attendees would like to speak to the committees today, please virtually raise your hand now. No hands are raised. Peter, do you have anyone with you in the conference room? It doesn't look like he does.
Thank you. Thank you to the chairs of the Behavioral Health Committee, all of those that you participated in today's meeting. It is 1:03 on March 12th, and this meeting's adjourned. Have a great day.